I'm here with e-patient Dave, and your talk today was excellent.
And I'm here with this guy. Is this amazing or what?
Excellent.
I'm
So,
glad you liked it.
yes, Dave, I mean, you've been talking a lot about empowering the patient, right, and what it means to empower the patient. You've been on this journey for a while now, and you have battled cancer yourself, and you think that moment where when exactly did you realize that empowering the patient can actually save lives?
So I want to do a clarification there because, a number of people, when they really think about what empowerment is, uh, it's not something other people do to somebody, right? The, the World Bank definition that I showed in my talk today, that empowerment happens by removing constraints. So, for instance, if you're walking a dog and you take off the leash, did you empower the dog? No, you removed a constraint so the dog can do what it wants. Now, that may or may not be a good idea, but my point is, so my book that I published in 2011 is titled Let Patients Help, right? And similar, it's really about letting patients contribute where they can if they want to. Now, some patients, the most important thing is for somebody to take care of them, which is absolutely fine with me. But like the patient stories that I told today, where patients are very actively involved in trying to essentially help healthcare achieve its potential by gathering data and so on. Those are cases where if society or paternal attitudes say, hey, patient, stop that. I'll take care of you, so shut up. That's crazy.
And I hear you, right? I'm trained as a physician in India, and this happens so often that the doctors classify patients as non-cooperative
Yes.
if they ever happen to come up with Google or an equivalent, right? And I think it's the same in the US as well.
And it's so well. It's as we've discussed, it is a cultural issue. And in the same way, people can think all kinds of erroneous cultural ideas that think a certain category of person is not capable of doing something, or that they are supposed to just stay in the background and do as they're told. I know there are thousands of cultural views around the world. My concern is where a belief erroneously holds back progress, or my favorite topic is helping healthcare achieve its potential. It's just, and it's really ironic when somebody wants to be arrogant and say, look, I know what I'm talking about, you don't, and that person is wrong. I mean,
Yeah. It's just happening more and more that doctors are sometimes being proven wrong by ChatGPT in your case, and again, it does. What does a doctor become in this future?
Well, so they are the expert consultant. I mean, every time I have a conversation with GPT or Claude or whatever, if I push far enough, I reach the point where I don't know what's going on. Even if I say, hey, GPT, I don't know what you meant by this, say more, or explain it like I'm 10 years old or something, there still comes a point where I don't know what's going on. I really don't know the mitochondria, cellular, all kinds of things. I still want my experts, but I also don't want my experts to say, shut up, you're bothering me.
Right, right. So tell me, how exactly did you go from a cancer patient and you had cancer, right?
I did. I was almost dead.
How exactly, what was your journey like? How did you navigate all of this? And when exactly did you realize that, oh, wait a second, this is wrong?
Well, it wasn't. I didn't know anything was wrong because during my cancer, my oncology team and my primary physician welcomed me being that way. It was only afterwards when I discovered that there were weaknesses in the health system and I started blogging and people started telling me to shut up, right? That I realized there was a problem and that maybe we could, well, very short. So when I was much younger, my very first encounter with getting treatment for anything non-trivial was I had a skin cancer on my nose. And so I went to see the doctor, and the doctor said, okay, we're going to take it off. And back then, it was a long time ago, it was an inpatient thing. And so I just, based on things I had read in magazines, I said, is there going to be a scar? It's not like it. And the doctor got mad at me. He said, I am a dermatologist. Now, today I know if somebody talks to me that way, I get out of there. But at the time, I thought he's the doctor. He must know what he's doing. And so it turns out the doctor did a much more aggressive big skin flap. So I have a big lump on the side of my nose. And never came to see me in the hospital. I had to check myself out 3 days later. I guess he showed me who's boss, right? So now, decades later, I just switched doctors until I found somebody who welcomed me asking questions. And so, and as I say, as it turns out, that helped save my life. According to my oncologist, right, as I said, in the British Medical Journal, the BMJ, the doctor said, I'm not sure you could have tolerated enough medicine if you hadn't been so involved. And then, as I say, other doctors started arguing about it. When the way that I ended up in the newspaper was my hospital was the first one to announce an interface to this thing called Google Health, which was going to gather all my data. And now we're still 15, 20 years later trying to do that. And it turns out that my hospital announced they had this interface because they had never tested it on real patient data. It's like, what are you thinking about? And so I couldn't get a straight answer. So I blogged about it, and then the newspaper called because electronic medical records were just getting started in the US, and ended up on the front page of the newspaper. And then people started asking me to give a speech at a conference. So anyway, here we are.
Yeah, I mean, I think this is a very personal problem as well. I feel it because when I was in medical training, right, when I was on the other side actually becoming a doctor, we were told again and again that you will get these difficult patients who are going to ask you all sorts of questions. And the whole alignment towards that was, you know what's best, and you are supposed to just shut most of these questions down, right? And I don't know, like, are we doing the medical profession a disservice by raising doctors this way?
So a really important thing that this gets to a deeper question of epistemology and the nature of knowledge itself. There's a magnificent book from, I think, about 2012 called The Half-Life of Facts.
Half-life of facts.
How long does a particular fact continue to be a fact? And the example that most people are familiar with is Pluto a planet? Right? And now there are people who think of changing that back and forth. Physics has the greatest longevity. Once something is a fact in physics, it doesn't change much. But it turns out medicine is the field that has the shortest half-life. And, many people have, and this is not rebellious patients, many people have written articles saying that the half-life of a medical education is, I don't remember what the number is, but by the time somebody has become an experienced doctor practicing for 20 years, it's something like a quarter of what they learned in medical school is still true the way they were taught it. And what's really important to me, some people think, well, wait a minute, every doctor should be on top of everything. And I think that's unrealistic. To me, the doctor is not the person who knows all the answers. The ideal doctor is the person who knows how to think about the evidence for my case. And that is something I may read every journal article in the world. That doesn't mean I know how to think like a doctor.
Yeah, I mean, and I think this comes to the overarching problem that doctors are taught what is good for an entire population, right? Like the research that they do
Yes.
is not for a particular person, and you don't know if that drug is going to work for you. They just know like this might kind of work for you.
Well, so it's great that you mentioned that because, as I said in my talk today, uh, when I joined this patient community, I got their perspectives as people who, in many cases, have been living with the disease for 10 years or more. And one of the first things they taught me is because the first thing everybody wants to know when they get diagnosed with stage 4 kidney cancer, renal cell, is this going to be fatal? Am I going to die? Right? What are my odds? What's my prognosis? And they said, just remember, you can look at all the statistics you want, but statistics apply to populations, not to individuals. And for me, it's funny because now we know more than we did back then about the effect that attitude and beliefs can have on somebody's survival. But for me, when I had just found out that my median survival was 24 weeks, I was probably going to be dead in less than 6 months. Number one, to meet people who got diagnosed 10 years ago and were still alive opened up a mental space of possibility. Now, and I knew, sure, all right, I'm probably dying, but I'm happy to shoot for the rare survivor case. And as it happens, I didn't mention this today, but I was diagnosed in January. Kidney came out in March rather. The interleukin treatment started in April and ended in July. 6 months after diagnosis, my treatment was finished. I haven't had anything since. It's like, woohoo for being an outlier. Well, but the thing is, it's medically invalid to say that doesn't happen.
Yeah. And that comes to, again, like you talked about faith and the role of belief in curing a patient, right? And definitely there's been a lot of studies on the placebo effect, but modern medicine still doesn't properly recognize that that is a factor in how.
Sure. Well, but there's a good reason for that. As I shared today, I'm trained in the scientific method. I don't work as a scientist, but I have some friends in the Parkinson's disease community, and there's been a big debate. The HIV/AIDS community back in the 80s told researchers, you SOBs are studying how this disease kills us. We want you to work on finding cures. And they finally convinced the scientists and the NIH funding to shift. The Parkinson's patients have no hope. They're watching their bodies and fall apart, and there's this deep brain stimulation is one of the things that they get. And there were concerns among scientists that some of that might be placebo effect. So they wanted to do sham surgery. Now, sham surgery, for those who don't know, is where you drill a hole in somebody's head and stick a needle into their brain, but don't flick the switch.
I think they injected distilled water instead of dopamine.
Well, and my friend Perry, who's now dead, he had 3 PhDs from MIT, so he understood placebo and all that stuff. And he said, the placebo effect, that whole idea of is that a sugar pill is inert and harmless. Drilling a hole in somebody's skull is not. And there was one trial, and this really gets into the challenging stuff of who should set priorities. There was one trial where unprecedented results were happening for multiple patients. Nobody knew why, but the people running the trial decided it was all placebo effect, and they stopped the trial. And the patients were saying, so study that. figure out what was happening and said, nope, that's not how we do things. Now, who should? It's I know we're talking about being on the frontier of knowledge, and that's there are going to be uncertain things, but I have a very strong view that if we're there to please the scientists, whether the patients like it or not, it's challenging for me to see that rationale, unless they are arrogant scientists. But if you're in the business in the first place to help the suffering people.
Yeah. I think the incentives have changed a lot over time, right? And I did read about this in a National Geographic article on the role of placebo and them drilling inside someone's brain and injecting distilled water, and then
that's a different one. I don't know that.
They got cured of all of their symptoms. They had a lot of tremors. Everything got cured because they injected distilled water, and it's like science can't explain it. But then the medical community, I don't know, the way the medical community seems to be working now is almost as if they think it's a proven science, where in reality there is a huge gap between what's actually good for the patient and what their knowledge tells them.
Well, and who says it's good for the patient? Right?
Exactly, right. So that should be the patient in the...
And I mean, one of the big disillusionments when I started getting involved in this, I really was like swept up in a tornado, and it was how I ended up going to all these meetings is improbable. But side effect of that is that I heard hundreds of presentations by people on related topics around healthcare. And one of the things I picked up that astounded me is that most NIH-funded studies are never replicated by another lab. And I mean, I knew just from doing bench lab work in college, if you can't get the same result twice, you're not sure that you've actually accomplished anything. All right. And of the, about the reproducibility initiative? They will, for a price, just go off and do another study. Again, and people don't like to use it. You know why? Because half the time the replication reverses the result.
Oh, no.
So essentially, by funding more new studies that may or may not be realistic, we're building more shaky pudding instead of firming up.
Yep.
But I mean, nobody wants, it's challenging to people's academic reputation. Anyway, this is why I love what people like PCORI, Patient-Centered Outcomes Research Institute, and other organizations are doing, listening to patient organizations increasingly about, essentially getting more patient-defined value out of every research dollar.
Right. And again, it's patients probably care the most about themselves, and they want what's best for them, whereas misaligned incentives everywhere else. Right?
Well, yes. And at the same time, I don't mean to suggest that it's all corrupt. There are people who say it's all corrupt, but humans are humans. And I think it's reasonable to look at the alignment of incentives. It's funny, but when I had cataract replacement surgery a few years ago, one eye had a surgical accident. And as I researched that, I discovered this surgical accident. It's called posterior capsular rupture with retained fragments.
PCR.
Yes, with retained fragments. Did you know that there are 3 articles in the peer-reviewed literature that refer to PCR as the dreaded complication?
Really?
Oh, really? Yeah.
I hear it. So both my parents are ophthalmologists. So every evening they come and they're like, if something has gone wrong, they're like, there's PCR all over the dinner table talk. So PCR is a pretty
and in my case, I had retained fragments.
Right.
So I had to go get a vitrectomy, which when I figured out what that meant, I said it to the doctors, and they really didn't like the way I described it. I said, so you're going to vacuum out my eyeball? And that's it. and fill it back up with saline. But I thought, wouldn't it be great? I mean, if I were an ophthalmologist who was really good at it, and I had a much lower rate of PCR than other people, I would want people in my community to know that I'm good at it. But it turns out that the industry has resisted measuring and reporting those numbers, which is just, that's the alignment of incentives problem. Now, I can't say that that's true everywhere, but in fact, as I researched this, I found out that there is only one measure of ophthalmology patient satisfaction that the government was tracking, which is, after cataract replacement, do you feel like your vision is better off than it used to be?
Okay.
And that measure is being stopped. They're not going to be reporting that anymore.
That's not even a measure. That's just like,
Well, but I mean, if there's any significant number, my point is just, yeah, humans are humans,
right.
But that's not really what we're here to talk about, right?
Right. No, I mean, do you think most of this has to do with the fact that doctors are seen as this above normal humans, or like they have this God complex?
Well,
right? So reporting a number on a being who's superior to everyone else is unethical, you know?
If you want to be irreverent, you can easily imagine a God figure stomping around heaven. Hey, what are you doing? Telling me I need new deodorant, you know? But I have had, so as a result of my work advocating for a new role for patients as an active partner, it's what we call participatory medicine, right? I have encountered doctors more so 15 years ago when I got started than lately, because I mean, among other things, 15 years later, the oldest doctors have retired and they've been replaced with newly trained ones. But I've had doctors come up to me after a speech and give me reactions. One guy came up to me and looked me in the eye. He said, "This is crap." This idea of patients being able to contribute, because his entire career, his training 45 years earlier, right, was that he's the one who knows things. He's the one who can save lives. And he probably has experience saving lives, right? And he hasn't seen a pathway for the patient to have any kind of contribution, right, and be thinking for themselves. But another doctor came up and, with real feeling on his face, said, "I was trained and I was taught by my mentors that my value as a human being is that I know things that other people don't. Now, if a patient has seen an article that I haven't, then who am I?" Right? And as I said before, I mean, you're the one who knows how to think through these things. You're the one who's seen thousands of patients and seen how cases progress. You've done differential diagnosis. The fact that I've seen an article doesn't approach that, right? But a very wise doctor said, when this was back when we were having the initial arguments in U.S. policy about whether patients should be allowed to look at visit notes. He said, the reason you're getting pushback from doctors is that they haven't been trained on how to work with a patient who has this information. It's just not in their skill set. And which, to me, that just creates a huge opportunity to, how can we develop and validate the way for doctors to think differently? With AI, it's just going to be really important. Because, people worry about trust in physicians is eroding. Well, if people start experiencing that sometimes they get valid answers at home and their doctor's out of date, That's just not going to be good for trust. And I think that's a shame because, when I think of the work that my primary physician, Dr. Danny Sands, did he worked harder in college, he went through medical school, and all of that stuff. I want him to have a good life and really be fulfilled.
So what is the solution here? Do you have any framework that we can apply?
Well, AI came along, GPT came along 2 years ago this month, right? It's early days and we're still
not just AI. I'm talking about the whole problem, which is doctors being more receptive to patient engagement.
You saw it today in my talk. I talked about parallels with the women's movement.
Yep.
The people used to think, women can't be CEOs, girls aren't athletic, and so on. You can view it as a new discovery, like, hey, new things are possible. Let's find out how it works. Let's figure it out together. And I hate the idea of adding something new to doctors' workload. But the reality is, I quoted that philosopher Eric Hoffer, right? In times of change, right, the learners inherit the earth.
Yes.
And the previously learned are equipped to deal with yesterday.
That doesn't exist anymore.
A world that doesn't exist anymore. So I'm just, I guess one other answer to what do we do about it. I love the fact that you and the Open Air and the HL7 fire people and so on are working on building the new future, right? Because we can all be better informed and better able to operate in a new way instead of all the burden being on all the knowledge has to be in your head. If we can have a common, it's just as with a financial advisor, we both look at my bank accounts together.
Yep. Patients are going to have access to more data than ever, and so are the practitioners.
Well, and just the fact that I can get an appointment with Dr. Google or Dr. GPT at 2:30 in the morning, as that mother, Courtney Hoffman, did, and I can't get an appointment with you right away, means people are going to be doing that because they can be, if they're worried and they want to take action or they want to at least understand.
Yep. So we have a lot of people who are doctors and practitioners on our channel who will probably listen to this. What is your key takeaway for the clinicians?
I'm truly grateful for the work you did to earn that title. As I'm fond of saying, in college, there were people who lived in my floor of the dormitory that we called the grade grubbing pre-meds. They worked harder, they partied less than me, and they earned the honor. What's possible is changing, and any skilled professional in any field naturally will want to keep up, or they're going to find that their colleagues are outracing them. And please, let's figure out together, how do we build new best practices in this world where new things are possible?
Excellent. This is e-patient Dave, and I'll put a link in the description on where you can find him. So Great. Thank you for taking the time. Thank you.
My pleasure. Thank you so much.